My topic of discussion for today is comparative study of incidence of posterior capsular opacification with hydrophilic versus hydrophobic acrylic posterior chamber IOLs after the cataract surgery. Financial disclosure, no financial interest. Introduction: posterior capsular opacification is also called secondary cataract, which is most frequent complication of the cataract surgery, and it has pearls, fibrotic membrane, and Sobering's ring. It is a multifactorial and physiological consequence of the cataract surgery with PCIOL. And PCO occurs with the residual lens epithelial cells on the residual anterior capsule, which undergo three phenomena, that is proliferation, migration, and normal or abnormal differentiation onto the posterior capsule. And the accumulated lens epithelial cells results in the opacification of posterior lens capsule. The choice of surgery and IOL are particularly important in relation to eliminating or least delaying the PCO. And the study was designed to compare the incidence of PCO formation after cataract surgery with relation to the age, preoperative cataract status, diabetes, hydrophilic and hydrophobic IOL implantation. My aim of the study is to evaluate the difference in the incidence of PCO between hydrophilic and hydrophobic intraocular lenses. Materials and methods: it's a prospective observational study which was conducted over a period of 6 months in the Department of Ophthalmology in RVM Institute. A total of 50 eyes of 37 patients with age-related cataract were included. Inclusion criteria: patients with post-dilated pupil size more than 6 mm, and patients who underwent uneventful cataract surgery, and patients with controlled diabetes and hypertension. Exclusion criteria is complicated cataract, history of prior ocular surgeries or inflammation, significant corneal scarring, uveitis, trauma, and patients aged less than 40 years. Preoperative evaluation: relevant medical history was taken, and subjective and objective grading of the type of cataract in relation to the lens zonule of opacification according to the lens opacity classification system 3. Further, the examination included the best corrected visual acuity, IOL biometry, slit lamp and anterior and posterior segment examination, and if posterior segment could not be seen, B-scan ultrasound was done. And the surgical technique is included phacoemulsification with in the bag IOL implantation. Patients were divided into two groups, in which group 1 included eyes which underwent cataract surgery with hydrophilic PCIOL, and group 2 include hydrophobic PCIOL. PCO analysis was done in subsequent follow-ups under a single experienced person, and further analysis was done with the help of retroilluminated images taken with the slit lamp guided anterior segment photography. Grading of PCO: grade 1 with no or slight PCO with normal red reflex, grade 2 is mild PCO reducing the red reflex, and grade 3 is moderate fibrosis or Elschin pearls inside the IOL edge but not at the visual axis. Grade 4 is severe Elschin pearls or fibrosis obscuring the visual axis and the red reflex. These are the grades of PCO. My results: group 1 has 23 eyes and group 2 has 27 eyes, in which most of the patients are under 51 to 70 years, and diabetes is present in 17% of the people in group 1 and 22 eyes in group 2. PCO grade comparison: my result is group 2 has more of grade 1 and grade 2 PCO, whereas grade 3 cataract is seen in group 1, which has hydrophilic IOLs. And according to age, less than 50 years age have more of grade 3 PCO, and it is more than 70 years age group has grade 1 to 2 PCO. According to the cataract status, patients with grade less than NO3, NC3 and C3P3 according to my study has grade 3 cataract more, and rest has grade 1 and grade 2 cataract. Discussion: it was demonstrated in the present study that the incidence of PCO formation is marginally more in the eyes implanted with hydrophilic IOLs as compared to the eyes implanted with the hydrophobic IOLs. Between these two groups, PCO was seen more in the young individuals, diabetic patients, and preoperative immature cataracts. The hydrophobic IOLs therefore has a higher contact angle measurement than the hydrophilic, which might be more difficult for lens epithelial cells to migrate. My limitations of the study are limited sample size, and study was conducted only for a 6 months period after the cataract surgery. And my conclusion is the incidence of PCO was higher with the hydrophilic IOL. However, the increased incidence of PCO can be attributed to young age of the patient, presence of diabetes mellitus and immature cataract growth. These are my references. Thank you.